Complex Care Case Study by Brooke, Savannah, and Zoe. So our patient is a 45-year-old male who came in via the EMS from urgent care. He had been receiving IV contrast dye for a CT scan, and after the CT scan was complete, he began to feel itchy, and then he went into cardiac arrest. So the nurses at urgent care performed CPR, and then the EMS arrived and took over CPR. They gave him 3 doses of 0.5 milligrams of epinephrine and 1 dose of 25 milligrams of Benadryl through his IV that they inserted into his forearm. And then he was transferred to the ER. The nursing practice issue with this is that the patient had an allergy to IV with contrast, and it was previously listed on his chart, but it had been taken off a couple weeks prior because the patient stated that he was no longer allergic.
In a research article that I found, it showed that primary, secondary, and tertiary prevention is a key to managing anaphylactic shock and how to prevent it. So for primary, you can figure out what your triggers are. Secondary, you can get allergy testing to figure out what you're allergic to. And then tertiary is like you've already had the anaphylactic shock and you need to learn how to manage it.
Our first critical thinking question is, what could have been done to prevent the patient from going into anaphylactic shock? As previously stated, the patient had an allergy alert to IV contrast dye on his chart. However, it was taken off, and then the patient received the IV contrast dye. Upon further investigation, the staff was able to determine that the patient was being treated prophylactically before receiving IV contrast dye with Benadryl. So the patient then and his wife were under the understanding that he was not allergic since he didn't have any reaction since he was being treated prophylactically. That is why the patient decided to have the allergies taken off of his chart.
So some communication and safety measures. The most important thing to start out with is determining roles for each healthcare provider before the patient ever arrives to the ER. So one nurse can be given the role of documentation. Another nurse will be given the role of administering medications that the doctor will be given verbal orders for. So it's really important with this that every time that the nurse administers a medication to verbalize to the nurse that's documenting what was given, what time it was given, what the dose was, and what the route was. That way the nurse can chart that, and that will increase effective communication. Another thing is that there should be 1 to 2 nurses dedicated to chest compressions. They can be very tiring, and so you want to make sure that the patient is getting adequate chest compressions. And you can do that by making sure that the nurses are switching out when they get tired and being able to recognize whenever one's chest compressions are not adequate. This form of communication allows the nurses to be able to use safety measures to make sure that a patient isn't being over or under medicated.
For the assessment of our patient, we use the ABCDEFGHI triage method. We start with the skin. You have hives, angioedema, flushing, and then we move to the airway, which you have dyspnea, wheezing due to the bronchoconstriction, and respiratory arrest. And then cardiac, it started out as palpitations with tachycardia, and it dropped in blood pressure, and then he ended up going into cardiac arrhythmia asystole. And then our nursing diagnosis is as followed.
The following are nursing interventions. Essentially what the staff did was once the patient arrived to the ER, they took over doing CPR. There were several nurses who did perform CPR. One important thing to keep in mind with our patient is he was around 380 pounds. So a lot of the nurses were getting tired easier or tired faster by doing compressions, just because they did have to push down with each compression further and harder than they normally would. Some of the nurses actually had to get on top of a stepping stool to effectively deliver compressions. So there were more people performing compressions and doing CPR with this patient than there would be with most other patients. While the patient was also receiving CPR, there was a nurse that did a full assessment on the patient. CPR was not stopped for this assessment to be completed. The patient was then placed into a Trendelenburg position so that the vital organs were still being perfused adequately since the patient was in that position. The patient was receiving 20 liters of oxygen via a bag valve mask. They were also placed on a continuous ECG monitoring system just to make sure that there were no new or reoccurring arrhythmias that were to happen. While CPR was taking place, the patient also received 3 additional doses of 0.5 milligrams of epinephrine. While this medication is delivered, the nurses were taking great care to monitor the heart rate, the blood pressure, and to also push the medication slowly. So the patient had one previous 18 gauge IV in the right forearm. However, that patient, or that IV I should say, came out, it became infiltrated, and so the nurses tried several times to get another large bore IV in place. However, with the way that everything was going on, they weren't able to effectively get an actual peripheral IV. So the patient ended up getting an IO because they still needed to get fluids and medication to him. Bicarbonate was given to the patient to correct the metabolic acidosis. It was given as a 50 milliliter IV push. Dextrose, 25 milliliters, was also given prophylactically to treat hypoglycemia. After 20 minutes of high quality CPR, the patient was intubated via the physician. This made sure that there was a patent airway and that the patient was receiving the appropriate amount of oxygen. After stabilization of the patient, a full set of vital signs were taken. Blood cultures and labs were also collected on the patient.
In a research article that I found, it showed that the following methods was effective in treating acute anaphylaxis. So adrenaline, epinephrine was the most important drug, but also posturing and making sure that the patient gets enough oxygen, fluid support, inhaled short-acting beta-2 agonist, H1 and H2 antihistamines, and glucocorticosteroids.
Our second critical thinking question is, what is the purpose and rationale of giving bicarbonate during a cardiac arrest? As we've stated in class several times, whenever oxygen delivery goes from an aerobic process to an anaerobic process, lactic acid tends to build up, and lactic acid, as its name suggests, is very acidic. So whenever the heart stops pumping acidic waste, then lactic acid builds up in the heart, and thus, the patient could go into an acidotic state. So by giving bicarbonate prophylactically, you're preventing that patient from going into an acidotic state.
As I said on my previous slide, the medications that were used with antihistamines, such as Benadryl for the patient, and the epinephrine works on alpha and beta adrenergic receptors, and it works by increasing vasoconstriction and increased peripheral vascular resistance, which raises the blood pressure, reduction of tissue edema, raised heart rate, bronchodilation, vasoconstriction in the skin and the mucosa, and inhibition of mediator release.
Our next critical thinking question is, which medication is more beneficial during a mild reaction versus a severe allergic reaction, epinephrine or antihistamine? So the answer is antihistamine. So one article that we found was by Ring, Klimek, and Warm. Did some studies and found that actually there's no real evidence-based practice that epinephrine is the most effective drug. It's still used because there's also no evidence that states that it's not effective. There's just not enough studies that have been done to prove its effectiveness yet.
So our fourth bonus critical thinking question is, why is it so important to practice good communication during a code? During a code, there's a lot going on, and it's very important to have the physician instruct the nurses what to do, so there's not multiple people trying to do the same thing and wasting time. It's essential that communication's instructed and everybody knows what to do before it happens, or if at least during it happens, the physician states what this nurse needs to do, what this nurse needs to do, so everybody's on the same page to help the patient the best. The physician could tell the nurse who are performing chest compressions when to pause and check for a pulse or for a rhythm on the ECG. And also the physician could be telling what medications need to be given and what nurse needs to be giving those medications, so the patient is getting treated in the best way possible. And these are our references.
Okay. So the end result of our patient during this case study is that he eventually went into a sinus bradycardia where they were able to stabilize him. They intubated him, and then he was sent to ICU for further treatment.